Thanks, guys. Appreciate you guys hanging around for the last part of the day. Thank you so much. It's better than talking to an empty hall. So I think anybody who learned something, it's good to get going. So I can't outdo Christian's talk from this morning, but I'll try to supplement it and review a little bit. So this is the one area in the body where the OTA-AO classification actually is useful. And largely we're going to be talking about the C3s, the 33 C3s, but we'll talk a little bit about C2s. You know, the injury considerations, they're always a complicated injury. They're usually associated with deforming forces that are problematic we have to overcome. I had to think a little bit about the shape of the bone. The distal part of the femur is a trapezoid. We all remember that from our teaching, and so you have to be careful of that when you're putting implants in and things like that. Everybody's seen this diagram. We've all grown up with it. And with this idea that there's this 99-degree angle of the knee. And did you ever stop and ask yourself, if it's 99 degrees, why are all the implants at 95? Right? And the question, of course, was if you assume you have a transverse fracture line and you assume there's no comminution, which there's rarely ever no comminution, then what happens is you get a 4-degree pre-stress with an AO construct where you could compress, but most of the time that doesn't exist, but still the implants are 95 degrees. Anyway, so I think one of the things that has happened, and I think we see it in the distal femur more than we see it any other area, is that for most of the faculty within the time of our career, there have been evolutions of techniques in plating. And really, the first thing I want to point out is this minimally invasive percutaneous osteosynthesis, or MIPO. This is from the original article Craddock wrote, and actually Ted Micklau is a co-author on this article. But this is where Christian was showing that if you do this subcutaneous pass of the plate, you don't disrupt the periosteal blood supply, where if you do it open, you tend to do that. So the idea that is minimally invasive, or MIPO technique, so that's a concept that has become important. The next concept that became important was lock plating. Over our career, this idea of not standard screw fixation, but lock screw fixation and static, this internal fixator as a concept has become popular. And the third concept that's happened at the same time is this anatomically pre-contoured plates. So almost never now, with the exception of maybe both bone forearm fracture and maybe some ankle fractures, do you just open a box with straight plates. There's some pre-contoured plate for the distal tibia, the proximal tibia, the distal femur, or some whatever it is you're using, right? So these concepts of the MIPO tech application, the lock screws, and the pre-contoured plates have really dominated everything. So it'll dominate our discussion. In 1999, I did my first list case. I was a trauma surgeon at UC Davis, and this fellow came in. He was having some kind of psychotic break and was on an overpass and jumped onto the highway and oncoming things and this and that, and he has his distal femur. So you can see it's fairly comminuted, and the distal femur, I'm looking at this going, what am I going to do with this? You know, I can't put a nail in it. I can't really open it up and put it all back together. And this concept of the MIPO concepts and the list plating had just literally come out like the year before. Never used it, dying for a case, and so here it is. So I thought, well, man, I'm going to give this a go. So we did. He had a relatively simple articular injury, so we put screws across the joint, and he had a patella injury, which we fixed, and then ultimately spanned, and then came back with our percutaneous bridge fixation. You can see the open incisions here in this patient. And sure enough, there's his initial post-op. And there he is after 3 months. And doggone it if the thing didn't heal. And as my father would say, I'll be a hootenanny. So that's one of those things that just, it works. So it's an interesting, exciting concept that we all take advantage of. So this, and I think one of the reasons this became so popular that a lot of our younger surgeons don't appreciate, but Tim and Andy and Kyle will, is this paper from 1991 from Sanders and Kwiatkowski, where they were having trouble with a standard distal femoral plating, and the problem was that it kept dropping into varus, and so they went with double plating. And I put this up here because, of course, double plating is becoming a thing again. But the reality is the problem then and the problem now is that you can get stability with double plating, but the joint gets stiff. And that's still a problem today. So with that as a backdrop, I want to just review a little bit of kind of augmenting what Christian talked about this morning. So you get this complex injury with a complex articular component, and you can do the parapatellar arthrotomy, no question. It gives you great access. And it gives you access like this where you clearly need to see the articular surface where you can really put it all together. And so you do that, you do this K-wire cage, you kind of put it in, and the guys from Harborview, look like you fell into a box of K-wires. There's wires everywhere. But the interesting thing about this that most people don't talk about much is that as you go to convert this to fixation, you have to be very careful because it's really easy, particularly with a fixed angle construct, for one of your screws to impact a K-wire and then secondarily impact your reduction. So you take all this time to put the reduction together, and then you put the K-wires in, and then you put your fixation on, you realize, damn it, I can't put it there. I got to change this wire, and I got to move it around, this and that. There's things people don't really talk about much, but they're practicalities of the work we're doing. One of the other things I pulled out of the past just for fun, I mentioned this to Tim last night. So John Charnley, one of his lesser-known works, John Charnley, of course, known well for arthroplasty, wrote this book on the closed treatment of common fractures in 1951. And one of the things he pointed out was this concept of what he called the master pad. And the idea was, you can see it being shown here, the idea was if you're going to treat a distal femur intraction, how do you keep it reduced? And you do it by putting the master pad under the knee. And so it turns out, lo and behold, you're in the OR, what do you use? You use Charnley's master pad to help reduce the fracture. So it's just these things that we continue to build on and evolve over time. So we end up with something, taking our K-wire cage and moving it more to a fixation construct that we can make sustainable, just as an example here. So one of the things that we learned the hard way was that with lock screws, they always have a good bite, regardless of how well opposed the plate is. And so we can talk about how we do that. And so I'm going to move on to our cases here. Just some points to remember as we're using these lock plating systems. Okay, so case one. So what do we have? This is our 67-year-old female, head-on motor vehicle accident, bilateral femurs, an open pilon, so there's always something going on in complex injuries. So have these complex issues of femurs. So put them in spanning frames.
How about just the initial evaluation? So patient comes into the emergency room, trauma team is involved, they're doing the resuscitation, vital signs are stable, and you walk in the room, you see these bilateral open femurs.
Yep.
So what as an orthopedic surgeon, what is it that you're going to offer our trauma team immediately to help manage this patient?
So we talked last section a little bit of ATLS and the hypotension, and so we talk about the airway, bones, and of course airway, breathing, circulation, right? So the orthopedics comes into ABC under C for circulation, for blood loss. So to Dr. Bray's point, so thoughts from the audience when you're on call, you have open joints. What things do you offer the team?
So the patient's got good, feet are nice and pink, good capillary refill, the head's okay, complaining of pain, trauma surgeons are becoming disinterested. Where do you go from there? You splint them in the emergency department, you try to call the operating room, you put traction pins in. What would be the ideal progression for initial stabilization?
I would prefer to take it to the operating room and put a spanning fixer.
Okay. Everybody agree with that? Anybody have other thoughts about it?
I think you could do it in the ER. We're certainly doing that at Charity. think about where you're gonna put your pins for like a femoral distractor. Now, you also said there's a pylon on one side, so you gotta be careful with it. But yeah, you can
So-
put a spanning X-Fix in the ICU, you can put it in the ER, it's.
So Fernando, in Mexico or other countries, would you use a spanning frame for this?
Not so much.
No, what would you use?
I think there are ways to relate this kind of information.
The traction, Fernando, initially?
It depends on the level of trauma of the hospital.
So I know one of the challenges that we rarely think about in other countries is that many times the cost of an external fixator is quite a lot. And so it may be that, you know, we think of a spanning frame and then discarding it in 2 weeks and don't think much about it at all. But yet in other places, there may be a limiting barrier. So it's just important just to mention, given the international nature of our.
So you're interested in advanced imaging at some point. So how would you construct your external fixator so it wouldn't interfere with, there you go.
There you go.
With your imaging, yeah.
So in this, I might, on the non-P-line side, I might get the do the CAT scan, fix it, you know, get that side fixed, definitively washed out and fixed, and then span it, because you're gonna span the P-line for sure. I never fix a P-line acutely. So I would do the spanning stuff on the P-line side.
Okay, yeah, I think it's probably most, everybody else at X-Fix initially.
Yeah.
Take them to the operating room, they're cleared, external fixator, careful about your pin placements because of your imaging. Antibiotics,
Yeah, they need to be given, you know, early, like in the ER.
okay.
So the question is why X-Fix it? Like, why not just put it in a split like Fernando does?
So
Anybody want to comment on that? Why
It's hard to put a distal femur fracture in a split. It just bends right at the point where your splint is. It's especially depending on the shape of the leg.
I'm sorry,
Not very-
say I couldn't,
It's not very effective immobilization for distal femur. It's hard to put a splint on. They tend to bend at the splint, at the fracture level.
it's hard to get it above far enough.
Yeah, unless you put a,
I guess,
all the way up to their,
so you're just trying to stabilize it. I think concern, of course, I haven't seen it as much, but people usually put them in traction or something. Femur shortens very quick. And if it's gonna be more than a day or two before you actually get it back, you're gonna have a hard time getting that out of the way. And I think that's why I would X-Fix it.
The other thing, I think hemodynamics, you got bilateral femur fractures
Yeah.
and a distal tibia. They're gonna lose some blood. So I like the idea of trying to stabilize them. These are hard fractures to fix. This is a lot of work.
Yep, it's a lot of work.
Yeah.
so are there any institutions where this patient would get TXA when they get to the ER with this kind of injury? Is that happening?
Say again?
TXA in the ED.
Like, we had a kid that bled out and died from open femur, like, you know, because it was a prolonged
Say
extraction.
like 4 units for a femur, we're talking about 8 units just in the femur. Plus being open makes it a little bit worse, so it's not half the lot.
And you don't know what the blood levels were. Okay, so we've got the patient
Yep.
emergency room.
Yep.
We've decided that we're gonna stabilize them, they're hemodynamically okay, they got their antibiotics. Trauma is losing interest.
Yep, yep.
Get them into the operating room.
Right.
And so,
And they're trying to point out that this pin, because it's lateral instead of anterior, could end up potentially being in the way if you choose plate.
okay. All right, so we like that so far, so we're not throwing too many tomatoes.
Say, go back to the film there where so you've got your tibial pins are A to P, right? And
Yes, sir.
femur pins are lateral.
Lateral, right. That's a problem potentially.
That's not the way I would do it. but
How would you do it?
I put my femur pins in A to P and the tibial pins.
Right. So if you choose,
Rivers, and I put 2 parallel
Right, so if you choose to use a plate laterally, it won't be in your way, or you choose to use a distractor in the operating room, you can do that.
The OR as a distractor too.
Right. Those are good points.
Kind
Those
of
are,
like anteromedially, but it's not so much different. I think you get some quadriceps scarring going directly anteriorly, so I kind of go more anteromedially. And then also,
Be close to the artery,
what's that?
close to the artery.
Right next to it. But generally, that artery's behind the knee where I'm going to put it, above the knee. But anyway, but the idea being is that even if I'm like plateaus, it's just always a good thing for, you got something on the medial side, thou shalt not embarrass, and it just kind of helps me hold the reduction a little bit.
Yeah, talking about the artery, I never use the self-drilling pins because the tip of the pin is the drill bit, and then you're sticking way, you know, the pin has to go way through the posterior cortex. And if you get a CT, which you're going to do, you'll see how close that is to the artery sometimes on that distal pin.
So we're okay anterior medial on the tibia and either straight or slightly anterior lateral on the femur. Is everybody okay with that?
No, I'm still anteromedial. I like anteromedial.
You like anterior medial?
Yeah.
Who wants to do anterior medial on the femur?
No.
Okay, who wants to go straight?
I go straight.
Straight. And who wants to go a little bit anterolateral?
That's okay.
Okay, all right, so consensus is the anterior medial tibia, sorry, Val, we're going straight anterior on the femur.
Yeah, you guys are, got a lot to learn.
Not just one,
All right, so what do we got, Steve? Oh, I'm sorry.
So quick question, at my hospital, these patients have a CT scan before they've even consulted us, and it always stops right above the fracture, so in this case, it's gonna stop at the mid-femur level. And you have those x-rays, do people, would you send the patient back to get a dedicated CT of the knee?
to get it. So what you're saying is it would stop above the knee?
Yeah, they do the scout, they always stop it above whatever orthopedic areas
Yeah.
of interest. I've tried to say, just go all the way down, and they never do.
Yeah, so absolutely, in our place, that would be a second trip if they didn't get it the first time. How about, and would everybody get a CT, anybody not get a CT for this?
Are both of those open? Both
Yeah.
of those
Yeah,
are
both
open?
So my philosophy is a CT is an expensive and an exam, it takes some time, it exposes the patient to radiation. Is it gonna change my management? And for distal femur fractures, might make a little different incision, but a lot of times, it's not gonna change the.
So if you know it's intra-articular, you're probably going to do a midline patellar arthrotomy anyway,
Yeah. So
as
sometimes-
opposed to a directed lateral. Is that your point, Andy? Yeah.
Yeah,
Yeah.
but looking at these x-rays, I might be comfortable going without a CT if for some reason they didn't have one already, and rather than go back to get a second one.
Well, it showed us we have I guess the one piece is this is kind of not speak code, but this lateral HOFO, which is that Christian talked about this morning, that posterior condylar fragment that sometimes cannot be appreciated.
But you appreciate it when you're looking at it.
If you know to expose it. Right.
All right, so we got the patient in the operating room, we got the frames on, stabilized.
Yep.
Up on the floor, ICU, or we just defer to the trauma team? Probably go to the ICU.
For sure.
Yeah.
Well, it's got a head
Yeah.
injury, right?
Yeah.
Head injury as well.
Right.
No, I think it was okay.
Okay.
All right, so where do we go? Okay, Steve, take us.
So further treatment, we know it's going to need fixation. I guess question of timing.
Okay.
So some of that, I think, is convenience in the sense of you want your best OR teams and your good help. You don't want to do this in the middle of the night necessarily. Reduction techniques, we discussed a little bit early on this idea of an open direct reduction, where you can do a MEPO in the proximal comminuted segment and bypass it, yet have an open articular segment. And who would use plates for these? Anybody want to not use plates? Anybody want to nail it or leave it in X-Fix?
Both are intra-articular?
Both are intra-articular.
Yep.
I'd like to see, does everybody have a trauma room that they get to work in, or or do you have to start this at 5 o'clock after the spines, right? Yeah. How many people have to start this after a line of elective cases? Okay, that just sucks.
That would last about 2 days in my.
Yeah, that just
I would
sucks.
not work in that environment.
Yeah, mean, everybody's a little bit different, but gosh, you know, get involved in that because, you know, this is the kind of stuff that just creates havoc for,
Yeah.
you know,
And-
the office, outcomes.
Right. And this is where the American,
Yeah.
yeah, this is where the American College has helped a little bit. So how many of you are working in a verified center, whether it's a 1, 2, or 3 trauma center? Because what the American College puts out, the Committee on Trauma from the American College of Surgeons puts out what's called the Optimal Resource Document, which is the document that details the resources needed to have a trauma center. And orthopedics for the OTA have been very effective working with the ACS, and so the dedicated ortho trauma room's in there. And so it's important if you can work administratively with your centers, if you're in a verified center, to get some of those resources. So that's an important piece of information to know.
Comments, questions? Yeah, just go to those meetings and beat on the administration about it. Even if it's not used 8 to 5 every day. I mean, if you get Monday, we started out like Monday, Wednesday, and Friday from, 7 to noon. And then, we had utilization. We then got it from 7 to 3. Then we had an extra day. So even if it's not 100% utilized, it just.
We got it all 5 days, and we made that part of the deal when I moved to Nashville and joined the private practice group. But we also got the total joint guys, the spine guys, and all those guys to fight for us too, because if we didn't have the trauma room, it would impact them, and they would have to deal with some of this stuff at 5 or 6 o'clock. So they went to bat with the administration. And
Yeah.
the administration loves the ortho service.
Oh, yeah.
So they really went to bat for us.
Yeah, good.
Good.
Anyway, I think
Sure.
that's just a little pet peeve
Yeah.
of mine. But as Steve said, there's a lot of literature on the importance of having a dedicated trauma room. Okay, so implants, who would consider retrograde nailing?
For locking plates, I used to do that.
So either, if it were just a 2-part condylar fracture, would anybody consider retrograding that, Andy?
Yeah.
Yeah, tell us about it.
Well, like everything else, the technology for nails, retrograde nails in particular, has gotten a lot better. There's a lot more interlocking screw options than there used to be. Some of the nails just had 2 interlocking screws in the same plane. Now you've got oblique screws, you've got screws going back in the condyles, even interlocking or locking into interlocking screws, I think. And even an integrated, plate system on that now. So I think that is an option. And my understanding of the current literature is that the results are fairly comparable. I've used it in people with bad skin wounds, elderly patients who are looking for a less invasive procedure. You tend to have better union rates, I think. Certainly better union rates than the lock plates that have about a 10% non-union risk, but the reduction is not quite as good sometimes.
Which speaks for the good indication for CT scan because, yeah, right? So yeah, I look at the CT scan to see if I can nail it. Yeah.
And the polar screws that Kyle talked about, the blocking screws can be really helpful for retrograde femoral nailing.
Steve, tell us what you did and why.
Well, so this is a list construct, as you can see, and it has a bypass. So use this MIPO technique, the same technique we talked about earlier, with an open distal articular approach, and then sub passing of the MIPO passing of the plate with a more open technique proximally. So I personally like to open it proximally outside of the fracture zone so I can make sure the plate's centered on the lateral femur. So I don't have to worry. So that imaging often is hard to get the guide managed up with the jig and everything else, but I find it easier just to directly put it on the femur so I know it's centered. And then take a little bit of time to make sure that the proximal end is on the femur, because sometimes you can get the 4th or 5th screw from the end on the femur and find out that the top of the plate's a little bit off, so you want to make sure you get that right.
I do them both at the same time?
I do them both sequentially. Not 2 teams, but one team do one, then do the other. And I think that helps both with managing length and managing rotation, to have them both prepped. And so, in the hip world, in the elective hip world, when you look at the assessing femoral version, it's common to have 10 degrees off between sides. So I think if you're close, and for me, meaning if I'll clinically look at the amount of internal external rotation, I think they're comparable. then that'll be okay with me. I think the patients that really suffer are the people that, where they lose all of they have no internal rotation, say they got just external, they can't internally rotate at all. Those are the people that really struggle. I think as long as you get a comparable symmetric rotation, you're going to do pretty well.
Tourniquet, no tourniquet?
No tourniquet, no tourniquet. If you need one sterilely, you can put it on, but,
No tourniquets, yeah.
yeah,
And you want as much blood flow down there as possible while you're doing the operation.
yep. And the question is, do you graft these, given comminution? I did not, but,
Okay. Anybody acutely bone graft?
No acute bone graft.
Okay, so no acute bone grafts, huh? Okay.
anybody else?
How about fake bone?
No.
Anybody want to stuff some stuff in there?
Don't open that metapseals.
That supracondylar area is very dangerous. And so if you can slide the plate in without getting into it, as Treg said, the non-unions here suck. And so you got to really, I like this technique because it keeps that all intact, and you actually never get into the hematoma if you do it correctly.
So I think the question here is, when do you weight bear this? Because there's some evidence on a unilateral side that you can allow them to weight bear as tolerated early on, but with both sides, you're all or none.
Yeah, I
So-
would not let a bilateral weight bear just, they're going to have too much pain, they're going to fall down, something
Yep.
like that's going to happen. It makes no sense to weight bear
Yep.
bilateral.
But, and I agree with you, I wouldn't weight bear them, but I would move them. Right. I would move them, range of motion, but not weight bear.
Yeah, I'd move them for sure.
Yeah.
So any-
Yes, sir.
Any consideration to adding a medial plate to let them weight bear?
Well, I think, have you used a list?
No.
So the reason I ask that is particularly the early titanium list plates are super flexible. So one of the things, I trained with Mike Chapman like Tim, and one of the things Mike always talked about was when you're done with your operation, assess your stability and so forth, and we would do that. But I remember the first time I used a list plate, when you could just move that thing around because titanium's so relatively flexible compared to stainless. So I think to your point is I would do a stability test, understanding I have a list plate. It might be a little bit more than usual. But if I think it's within normal for a list, and you ask me what that is, and it's because I've done a few, then I don't think I would add a medial plate for the reasons we talked about earlier. I think it's a biologic insult, and it really causes some joints to be pretty stiff. Andy or Kyle, do you guys use medial plates in these?
You go back to your X-ray. So it's, I don't think Cynthia's had any idea what they got into with the list plate, but I was one of the early things. I mean, I let Standard and Krieger do it first, so I wasn't sure, but they kind of convinced me. So yes, I've done tons of these, and I'm amazed, like in these vascular paths. I've treated distal femurs every which way but loose. You leave 3 to 4 screws open, so your fracture line is probably too big for that. But I see callus at 4 weeks. I've never seen that in any other way, nailing everything else. And so it happens to be the right biomechanical environment to optimize healing. And so now I don't think you need bone graft. I don't feel a bit strongly about weight bearing. I'm still waiting for that paper from Emil to show me that there's a benefit of that.
I think the hard part is having patience.
Is this a 13 hole? Because it looks really short.
I'm not sure what length it is, Kyle. Could be.
It looks too short. I would have gone with the long, always go long.
You would have gone with a longer plate, maybe more pins, more screw spread.
Yeah, more spread.
Much longer.
Well, this wasn't done this year,
No.
so, we didn't know that back then. Fernando, would you weight bear immediately?
About the peel
No,
on.
but move let's say,
Passive motion of the knee? When do they weight bear?
we're very, 1 month,
1 month?
gradually increase the weight.
Okay. And no bone graft?
No.
Do you use, for cases like that, do you use the knee brace ever or some kind of support externally?
It could be.
Okay.
There's a question
About
here.
the peel on.
Yeah,
Okay. I don't know. I focused on my femurs. I'm sorry.
All right,
It's an section.
any questions or concerns? Anybody want to yak at Steve about anything? I think you did a pretty good job. I may have nailed that one.
Okay.
I think I
Well,
would nail that one.
This is, I'll just run through this quickly. This is, to your point, we're assuming, I don't have trig CT, I apologize, trig, but I'm gonna have to assume this is distal femoral blocks intact. And so, in this case, the nail. So worth talking about some potential blocking screws over here like Kyle was referring to earlier.
When you do your blocking screws, do you put a drill bit in there and use that as a blocking thing and then then nail it?
In some of the Synthes sets, to your point, they have a bit that basically has, so that the distal half inch of the bit is a drill bit and the rest of it's a smooth pin. And those I will use as my blocking screws and then put the nail in and then substitute them for screws at the end.
One of the companies has a jig did that.
Right, right,
That's,
right. So I just wanted to show that, because we were discussing.
great.
Fair enough.